Sir, with all your permission, I'm starting this session. We are live now.
Yeah,
Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Keshav Murthy CB, sir. Sir has done MBBS, MD in General Medicine, DM in Cardiology, DNB Cardiology, and he is consulted at Manipur Hospital, Mysore. Today, sir is going to discuss on a topic, Arrhythmias and Heart. Let me tell you overview of the topic. Arrhythmias are the group of condition characterized by abnormal heart rhythms, which can significantly impact cardiac function. And understanding arrhythmias, underlying cause, risk factor, and consequences is crucial for accurate diagnosis and effective treatment. To know more about this topic, I would like to invite sir and hand over the session to sir. Over to you, sir. Kindly proceed from here.
namaste. Thank you all for joining this session. Cardiac arrhythmias is a very huge topic and sometimes very difficult to understand for people who begin understanding the cardiac arrhythmias, but I've tried to make it as simple as possible and dealing with only the ECG part of arrhythmias, the brady and the tachyarrhythmias, and very briefly touch upon the heart blocks today. So these are basically ECGs, which will help you to recognize the arrhythmia. Maybe treatment we can have subsequently. So cardiac arrhythmia is a group of conditions in which the electrical activity of the heart is irregular or is faster or slower than normal. That is the simplest of definition of a cardiac arrhythmia. Cardiac rhythm means everything is happening rhythmically, smoothly. There is a sequential activation of the heart muscles. We know that heart is one of the organs in the body where there is an electrical activity which initiates contraction of the muscle. Followed by that, there is a mechanical activity, which is the contraction and ejection of the blood, and which supplies the cardiac output to the entire body. This is one organ where electromechanical association is most important and it is essential for life. Even in skeletal muscles, you see that there is electromechanical activity, electromechanical association. That means whenever we want to move, we contract a muscle voluntarily. But in the heart, it's extremely important because that sequence of cardiac activation, the cardiac cycle has to be maintained for a human being to be alive. Therefore, it is very important for us to understand various rhythm abnormalities, separate what is normal and physiological from what is pathological. And sometimes the heart rhythm seems to be treated in a very emergent manner. Means within a few minutes, if we do not treat, there will be no cardiac output and the patient will be dead. Some of these conditions have electrical treatment. Some of them have pharmacological treatment. So which to diagnose, when to diagnose, and what treatment to give, and how to diagnose is the challenge for the day. So this we know is the conduction system of the heart, where the sinoatrial node or pacemaker of the heart, which is the dominant electrical activator of the heart, lies at the junction of the superior vena cava and the right atrium. It produces what is called as the sinus activity, which then propagates through the atria to the AV node, and through the AV node bundle of His, it is transmitted to the ventricles. Then the right bundle, left bundle, the Purkinje fibers, and the entire heart muscle gets activated in this manner. So it is important to understand the sequence of activation, to understand the sequence of how the arrhythmias arise, how the normal rhythm occurs, and then how the rhythm can become abnormal. So to have a basic understanding of the electrical sequence is important. Suppose the sinus node doesn't function. There are other pacemakers in the heart which take over from the atrium or the upper part of the AV node, which can produce stable rhythms which can sustain life. This is the protective mechanism that we have in the heart to maintain a rhythm when the sinus node fails. So these can maintain the rhythm so that the person is alive till the condition is recognized and appropriate treatment is given. So as we know from the heart physiology, heart has its own intrinsic rhythmicity, that is the AV nodes, the upper part of the AV node can still give beats from 40 to 50 beats per minute. The lower part of the AV node can give 30 to 40 beats per minute. Even the bundles can produce rhythms of their own, which can cause capture of the heart and produce cardiac output. When that even fails, the ventricular muscles themselves keep on contracting when isolated. Even when completely isolated from the conducting system, the heart muscles can continue to contract and produce some cardiac output at the rate of, say, 20 to 30 beats per minute, so that a last effort is made to keep the person alive. And even when that fails, when there is electromechanical dissociation, the electrical activity and the mechanical activity are not connected, there can be no cardiac output. Then we have a cardiac arrest, and the person dies within about 3 to 5 minutes of a cardiac arrest. We all know that. So this we discussed in the last class, how the P waves, QRS, the PR interval, the T wave, and the QT occur on the ECG, and the electrical correlation of the mechanical activity we have seen in the last class as the normal ECG. So this is again for revision purpose. This is a normal ECG, the PQRS sequence, the P wave, the PR interval, the QRS complex, then the ST segment, the T wave, all occur sequentially, and the electrical events precede the mechanical event. That means once there is an electrical activation, it is followed by a contraction of the appropriate part of the heart. Then there is a deep repolarization where there is relaxation or the diastole. So the electrical activity, the systole and the diastole of the ventricles are sequentially connected. So what is an arrhythmia? Basically, arrhythmia, the word by itself means that rhythm is a normal sequential activation. A rhythm, arrhythmia, means anything other than the sinus rhythm is called as an arrhythmia. So the commonest arrhythmia that we see, the commonest physiological arrhythmia is sinus tachycardia. That is when the sinus node gives the heart rate at a higher rate whenever there is a physiological requirement, like we are running or doing some physical activity or emotional excitement or fever or any other physiological. As a physiological response, the body increases the heart rate to give an adequate cardiac output for that appropriate activity. Suppose we rest, and when we say we are doing a peak exercise, if the cardiac output is the same, it will not work out. We will faint, isn't it, if there is not enough cardiac output. So to compensate and produce equivalent cardiac output, the heart increases the rate. So in sinus tachycardia, heart rates are usually more than 100 beats per minute. The rhythm is absolutely regular. If you see the RR intervals, they are regular. And the PQRS relationship is absolutely maintained. The PR interval is the same, and PQRS are identical to each other, and they're related to each other. And the QRS is usually normal in width and height. There is not much change in that. So this is sinus tachycardia. We should recognize it from other rapid arrhythmia so that we don't inappropriately treat something. Sinus tachycardia beats can go up to 160, even 180 in healthy adults, sometimes up to 200, but it is unusual to have rates beyond 180 in healthy individuals. In infants and young children, the sinus tachycardia rates may exceed 200 also, especially when children cry or active, can go up to 200. But thereafter, the sinus node matures, and you can see rates up to 160 or 180. Anything beyond that, you have to look at carefully whether it is an arrhythmia, like an ectopic atrial tachycardia, or something which looks very similar to sinus tachycardia, but it's an abnormal rhythm. It is not arising from the sinus. So this is another example of sinus tachycardia. The PQRS are very closely related. The ST segments are normal. The QRS is absolutely regular. The RR intervals, which we see in the rhythm leads, are all very, very regular. So this is an example of sinus tachycardia. Very simple and easy to make out. So the second commonest thing, which very closely resembles sinus tachycardia, is sinus arrhythmia, which is nothing but the respiratory variation of the heartbeat. We all know that respiration and the cardiac activity are very closely linked, and with each inspiration and expiration, there is a variation in the heart rate. So when you see that all the P waves and the QRS complexes are looking normal, but there is a phasic variation of the heart rate. That means when we take an inspiration, the rate increases. When we expire, it slows down. So that kind of rhythmic variation, which is associated with respiration, is called as sinus arrhythmia. We have to be careful about this and distinguish it from other kind of notorious arrhythmias, which may closely resemble this. For example, sinoatrial exit blocks. It's impossible to make out them from sometimes from sinus arrhythmia, except by doing electrophysiological studies, especially in infants and small children, where the sinus, the vagal activity is strong. You can have longer gap into RR, longer RR intervals. It may be difficult to make out whether it is a heart block or whether it is a sinus arrhythmia. But if you see a phasic variation, especially when you are observing on the monitor and continuous rhythm is being seen, it is termed as sinus arrhythmia. It's an innocent arrhythmia, doesn't require any particular treatment. So this is another example where you see absolutely normal PR intervals, QRS is normal, and they're coming regularly, except that there is a phasic variation. Here they become longer and longer gaps, and then again they become normal. That is the important point that we have to observe for sinus arrhythmia. Next is sinus bradycardia, where the heart rate has slowed down. Here you notice that the P wave, the QRS complexes are all normal. They are normal looking. There's no abnormality. They are fairly regular. And each P wave is followed by a QRS complex. Each P wave has a QRS complex. But the rate is slower than 60 beats per minute. Then you term it as sinus bradycardia. Most of the time, sinus bradycardia is physiological, especially in people, marathon runners who exercise regularly, excessive vagal tone. Some of the drugs like beta blockers very commonly cause sinus bradycardia, but you have to distinguish it from pathological bradycardia, which may occur due to various diseases, even in some of the fevers or infections, or even inferior wall myocardial infarction, ischemia of the conduction system. All these can cause bradycardia. You have to carefully look at what has caused that. Sinus bradycardia doesn't usually produce a very significant fall in cardiac output unless it becomes extreme sinus bradycardia. When the rates fall below 40, patient can have low cardiac output and can become symptomatic. Till then, no treatment is required. And simply by reducing the vagal tone, by giving vagolytic drugs, you can increase the heart rate if it is a physiological one. So now comes the other arrhythmias, the pathological arrhythmias. This is one example of atrial tachycardia. What do we observe here? We observe there is a P wave, there is a QRS, and P and QRS are consistently related. There's no change in the relationship between the P and the QRS. But what has happened is P waves are inverted in 2, 3, and AVF, which is indicating that the rhythm is not originating from the sinus node because the P wave axis has changed. It is probably arising from lower part of the atria. And therefore, we call it as a atrial tachycardia or a ectopic atrial tachycardia. That means sinus node is not functioning for some reason, or sinus node has been taken over by another area of the heart, which is giving a consistent and regular heartbeat. Generally, secondary to some causes like drugs or toxins or fever or myocarditis, hypoxia, these secondary causes, and doesn't require any specific treatment unless the atrial tachycardia rates exceed 180 or patient is symptomatic, when you can give calcium channel blockers and control the rate. So here you see the same atrial tachycardia, but it has become multifocal. You can see multiple morphologies of the P wave. See one morphology, P wave is looking pointed. Second morphology, PR interval has also slightly changed. Here also PR interval is shorter. Different morphology. So when you see 3 or more different morphologies of the P waves, it is called as multifocal atrial tachycardia, very common in patients with chronic obstructive pulmonary disease. Secondary to hypoxia. You also see that the axis has changed here. It has become right axis and multiple morphologies of the P waves. The cardiac rhythm is maintained. The cardiac output is maintained, not life-threatening, but if the rate is too much, if there is tachycardia, you have to control it. This is multifocal atrial tachycardia. So now one of the commonest arrhythmias that we see in clinical practice is supraventricular tachycardia, where you see that the rate is like 180 to 220. The QRS is narrow. You see that the QRS is narrow and regular. So what has happened? The rhythm has become fast, narrow, regular. So when it is fast, narrow, regular, and you can see some P waves, if you carefully observe, the terminal portion of the QRS can have some P waves. You can see some P waves at the terminal part, especially in inferior leads or in V1. If you take the ECG at a faster speed, say 50 millimeters per second instead of 25 millimeters per second, you will be able to make out the P waves. Of course, you can use esophageal leads or other kind of leads to make out the P waves. But when you see that, then there is a relationship between the QRS and the P wave. Sometimes it may come in the ST segment, sometimes it may fall on the T wave also. So you can say that this is still the origin of the arrhythmia is from above the AV node. That's why we call it as a supraventricular tachycardia. Fairly easily treated with beta blockers, adenosine, calcium channel blockers. But the most important treatment advance that we see now is it can be easily ablated with a radio frequency current, which is placed at the appropriate spot. That can be curative, and about 99% of the patients need not take any further medication. Now, some of the pathological arrhythmias, when the atrium get enlarged and they become dysrhythmic, this condition occurs. This is called as atrial flutter. You see that the rate is between 220 to 430. The ventricular rate is usually controlled by the AV node. That means not all the P waves are conducted to the ventricles. Usually they reach the ventricular ratio of 4:1 or 3:1, sometimes 2:1, so that the RR becomes totally irregular. RR intervals are not related to each other at all. So it is fast, narrow, irregular. Then it becomes atrial flutter. If you see this typical sawtooth appearance of P waves, you see here sawtooth appearance. The rhythm is variable. If you have a fixed block like a 3:1 or a 4:1, and if the block becomes fixed, then RR can become relatively regular. So you cannot measure the PR interval because the QRS complexes are not related to the preceding P wave. QRS is usually normal and narrow, and this is how you recognize the atrial flutter. The most characteristic feature of flutter is that the sawtooth appearance of the P waves. So flutter and fibrillation, sometimes you cannot make out. When the sawtooth becomes very fine, it becomes like a atrial fibrillation. They merge into each other. Atrial flutter is a fairly transient arrhythmia and usually quickly degenerates into atrial fibrillation, rarely into sinus rhythm. So this is another example of atrial flutter. You can see the sawtooth appearance of the P waves and the QRS being narrow and irregular. So next is atrial fibrillation, which is one of the commonest sustained narrow QRS tachycardias, commonest, sustained, and one of the most important clinical problems today with the population aging. There is more and more atrial fibrillation, which is attributed to underlying causes of left atrial enlargement or right atrial enlargement due to hypertension, ischemic heart disease, diabetes, obesity, various other factors lead to atrial fibrillation. And with age, with increasing age, with each decade of life, there is a 1% increase in atrial fibrillation in the population. Most important problem is it leads to strokes. If left untreated, there is clotting in the atria, which can embolize and cause strokes. So we have to control the rate. We have to control the embolic complications. So the most characteristic feature of atrial fibrillation is the rate is fast most of the times, unless we have intervened with drugs or ablated them. It is fast, the QRS is narrow, and it is irregular. So if you see an arrhythmia which is fast, narrow, irregular, most of the times you can close your eyes and say it is atrial fibrillation. You cannot see the P waves. You cannot see any clear-cut P waves in any of the leads. So though you may see some baseline fluctuation or waviness of the baseline in V1, and sometimes in inferior leads, you will not be able to make out any distinct pattern of P waves. So in such a case, you call it as atrial fibrillation. If you see sawtooth P waves, you call it as flutter. If you see fine fibrillary waves, you term it as atrial fibrillation. So that's how they're distinguished. So this is another arrhythmia, junctional tachycardia, where you don't see that wavy pattern, but you see no P waves. There are no P waves. The rhythm is arising from the junction. The QRS is narrow and it is fairly regular. If you see a fast, narrow, regular arrhythmia, it is junctional tachycardia. If it is fast, narrow, irregular, it may be atrial fibrillation or atrial flutter. So that is the only difference. Now, transiently, we touch upon the heart blocks, the first degree AV block, where you see that the rhythm is fairly regular, the QRS is narrow, but what has happened here? The PR interval has got prolonged. Normally 0.12 to 0.20, one large square, but here it has become more than 0.20. Sometimes it may become extreme. Sometimes even it may go up to 1 second PR interval. That is called as a first degree heart block. There is a delay in conduction in the AV node leading to first degree heart block. Usually by itself, it doesn't require any treatment. There may be ischemia, myocarditis, some underlying cause, beta blockade, which needs to be reduced, but per se it doesn't require unless it degenerates into further, progresses into type 2. So this is second degree AV block. What are we seeing here? In type 1, we see that there is progressive PR interval prolongation. You see the PR interval here, 0.2. It becomes 0.24, then it becomes 0.28. Then suddenly you see that the P wave is there. There is no QRS. This is called as Mobitz type 1 or Wenckebach phenomenon, commonly seen in inferior myocardial infarction or as an effect of drugs. It is transient. And by itself, it may not require treatment. Whereas in type 2, what has happened is the PR interval is fixed. PR interval is normal. PR interval is 0.2 or less, but suddenly you see that the QRS is dropped. This arrhythmia is notorious in that it can cause syncope and advanced heart blocks and requires to be treated. It also has a type where you can see 2 P waves and 1 QRS, 2 P waves, 1 QRS, but the PR interval, the PQRS relationship is maintained for every beat that has a QRS complex. So this is called as a 2:1. It may occur as a 3:1 block also, 4:1 with extreme bradycardia. So these are the second degree AV blocks. Then there is complete AV block where there is no relationship between the P and the QRS. There is no AV conduction at all. The atria are beating independently of the ventricle. So atria will have their own rate, say around 100, 75 or something, whereas the ventricular rate depends on where the ventricle is getting activated from. Like I said, lower part of the AV node, the fascicles or the idioventricular rhythm itself, the QRS can be narrow and it is generally slower than the atria as a natural sequence. This is an example of ECG of complete heart block. Complete heart block, when transient and associated with inferior wall myocardial infarction, it can revert to normal. But if randomly, if you see a patient who walks in with a complete heart block without ischemia, it definitely requires treatment in the form of a pacemaker implantation. Now we'll come to the ventricular rhythms, the ventricular ectopy. What do you see here? A normal QRS, normal QRS. This QRS doesn't resemble any of the prior QRS complexes. There is no preceding P wave. The QRS is wide. There are secondary ST and T wave changes. This is how you identify a ventricular ectopic. So this is a ventricular ectopic because the QRS is wide. Secondary ST and T wave changes, absence of the P wave is followed usually by a compensatory pause, unless it is an interpolated VPC. It is followed by a compensatory pause. That means this interval is longer than the preceding TP interval. So this is longer. So that is called as the compensatory pause. So ventricular bigemini, various types of ectopics can occur. An ectopic can come after every normal beat. Sinus beat, ectopic, sinus beat, ectopic. So each QRS, which is from the sinus, is followed by an ectopic. It's called as a bigemini. Then it can become a trigemini or a quadrigemini. That means every third or fourth beat is an ectopic. So this is another arrhythmia which arises from the fascicles. It is narrow QRS, it is fast, and it is regular, but it is a ventricular tachycardia. It's not an atrial tachycardia. So this is difficult to recognize from a supraventricular tachycardia, commonly misdiagnosed as a supraventricular tachycardia. But you can see that there are no P waves in any part of the QRS. Sometimes in supraventricular tachycardias, the P waves gets hidden in the terminal part of the QRS or in the ST segment or on the T wave. But here you see that there are no P waves. Then you have non-sustained ventricular tachycardia. After Bigemini, Trigemini, Quadrigemini, you can have sustained QRS complexes which are ectopic in origin. They are broader, they look abnormal, and they are more than 3 in number or last for more than 30 seconds. They are called as less than 30 seconds. They are called as non-sustained ventricular tachycardia. Here you see that a sinus beat, two sinus beats, they are followed by 4 ectopic beats. Sinus beat, sinus beat, sinus beat, then 4 ectopic suddenly. So it can quickly degenerate into ventricular tachycardia and can cause life-threatening ventricular rhythms like this one. So the commonest one is rhythm we see, the commonest mortal arrhythmia we see is ventricular tachycardia, where the QRS is broad, it is regular, it is fast. So if you see something which is fast, broad, regular, it is a ventricular tachycardia. Most ventricular tachycardias cause hemodynamic instability. That means patient becomes unstable, quickly degenerates into VF and arrest. So this requires very urgent treatment. Very rarely we see patients who come to the outpatient with a ventricular tachycardia which is ongoing and hemodynamically stable, especially in the presence of normal ventricular functions. Those are different and therapy is slightly different. We can deal with that in the next class. So this is one example of polymorphic ventricular tachycardia. What I showed in the previous slide is arising from a single focus. So all the complexes look similar to each other. It can be polymorphic in what is called as torsade D pointers, which is usually due to drug toxicity, any antiarrhythmic drug toxicity, which prolong the QT interval, congenital long QT syndromes, all these can produce torsade. This is called torsade, where you see that the QRS complexes are formed, but they seem to rotate around the axis, rotate around the straight line. So that is called as the torsade. This requires electrical cardioversion or correction of underlying abnormality, intravenous magnesium, and it requires urgent treatment. Torsade can quickly become a ventricular fibrillation and kill the patient. Next comes the ventricular flutter. So what is the difference between ventricular tachycardia and flutter? It is usually the rate. So it is fast, broad, and regular. And you can see that still the QRS morphology can make out. There is some morphology. So that you call it as ventricular flutter. Very fatal arrhythmia, quickly degenerates into fibrillation unless treated. And patient is almost always hemodynamically unstable, or many times patient is unconscious. So this is the most fatal of all. Most of our patients die from this arrhythmia. It's ventricular fibrillation. So where you see that there is no recognizable QRS form, it is just a wavy form, just like in atrial fibrillation. This ventricular fibrillation, totally irregular, fast, and there is no particular morphology that you can make out. If you see that, if you have put the leads properly, it is ventricular fibrillation, which requires almost immediate treatment within a few seconds. You have to electrically cardiovert this patient, otherwise they most certainly go to succumb to that. This is an arrhythmia called as electro-mechanical dissociation, where you see some electrical activity. It is not resembling any of the normal QRS complexes. There is no preceding P wave. It is slow, usually about 20 to 30 beats per minute. And it may be irregular or regular. So this we call it as a idioventricular rhythm or an electromechanical dissociation. Why we call it as a dissociation means there is electrical activity, but there is no recognizable pulse. This you see especially after resuscitation. We are given a lot of adrenaline, atropine, CPR. Then you see the rhythm, you see some electrical activity coming on the monitor, but that doesn't correspond with a pulse either at the periphery or in the carotid. So that you call it as electromechanical dissociation, which usually progresses to a complete arrest. So this is one arrhythmia I don't want to see, the cardiac systole, where there is absolutely no electrical activity, all the leads are flat. One care you have to take is to make sure that the leads are properly connected. You should not declare a patient who has electrical activity as an system. So that is about it for today, and thank you all for your attention. I hope you all had some brief learning experience. As I said, in about 20-25 minutes, it's difficult to cover the whole gamut of arrhythmias and their treatment, but I've done my best to give a brief overview of some of the common arrhythmias that you will see in clinical practice on the monitor in your day-to-day practice ECGs. Thank you all for being here, and thank you all for your attention. We can have a couple of questions and then.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session an informative one, sir. I definitely think this session knowledge is going to help all the participant doctors who have joined the session. I can see there are questions from Dr. Viswanathan. He is asking, what are the best way to identify the arrhythmias on the initial stage? What clinical examination should we do?
Arrhythmias cannot be identified by clinical examination alone. You require to put some kind of monitor, because sometimes you can feel the pulse, there may not be any electrical activity which corresponds with that. So you have to have a monitor connected or take a 12-lead ECG. So the ideal thing to recognize an arrhythmia is to do a 12-lead ECG with a rhythm strip and identify what kind of rhythm it is, and then appropriately treat that. That is the best way.
Thank you so much, sir, for answering it. Another question from Dr. Agarwal, and he is asking, like, what are the scale so that we can judge we can understand, like, this is the perfect motion of the arrhythmias or it is not?
So you have standard ECG scales, which give, in most of the modern ECG machines, they are automatically adjusted so that you get the appropriate kind of reading. So from a properly taken 12-lead ECG, you can make out that the speed is about 25 millimeter per second, and the standardization of the height of the complexes is 1 millivolt is 10 small squares. So if you use this as the common measure, you can make out most of the QRS complexes, heights, and standardize the rates and rhythms.
Thank you so much, sir, for answering all the questions. We have Dr. Anjali. She has written wonderful presentation and must discuss topic to be done. Thank you so much for the presentation.
Sure.
Sir, as there is no more question from the participant, and with all your permission, shall we conclude this session, sir?
Absolutely. Thank you.
Okay, thank you so much, sir, once again for giving your valuable time. Hope to see